Hello everyone. Thank you for joining Medflix 2021 virtually from the comfort of your own phone and practice. The topic that we will be discussing today will be warding off vaginal infection, a real-world approach. Before we proceed, we have few housekeeping details to go through with you guys. The live stream session today will work based on webinar formats. The speakers will be delivering their various talks, followed by a panel of Q&A sessions. If you look to the right side of your screen, there's a button, Present, which you can click on this to submit the questions. Throughout the stream, you may opt to put your questions up in the panels. The questions will be directed by the session moderator to the speaker to discuss if time permits. So without further ado, I would like to initiate today's sessions. Vaginal infections is one of the most common reasons why women visit the clinics. It is estimated by up to 10 million women visit the clinics due to this reason. If we dive into the local vaginal infections, 4 common encountered infections are bacterial vaginosis, vulvar candidiasis, mixed infections, and trichomonas. These infections can occur in different stages in women's life and usually negatively impact the women's quality of life. We have the honor to visit 2 experienced ONG doctors for today's discussion today, where their valuable insight in managing vaginal infection can help the audience to diagnose and treat the vaginal infections with strategic mind. Please welcome Dr. Raman and Dr. Kiren. So how is Dr. Raman and Dr. Kiren doing today?
Fine, thank you.
Thank you.
Let's get on with our first question then. I'm sure that the audience is eager to find out what is the general approach as a clinician to diagnose or treat the vaginal infections? Perhaps we start with Dr. Kiren.
Thank you. Okay, so basically, for a common vaginal infection is a common problem. Some women come in complaining of vaginal discharge, and it is important for us to establish whether it is something that we need to treat or whether it is something that is physiological. So it always starts off to decide whether something is physiological or something that is pathological, as in infective. And if it is infective, then what kind of infection we are dealing with and appropriately treat it. The usual steps of managing an vaginal infection in a clinic setting is to take an adequate history with regards to what it is that they are facing. With regards to timing with the menstrual cycle, sexual history, types of discharge, and then continuing on then to the physical examination, trying to identify what it is, and then the necessary investigations, and then coming forward with the management. So in each person who has a vaginal discharge, pretty much this is usually the flow of how we would deal with someone with that kind of condition. What do you think, Dr. Raman?
Yes, I would agree with what Dr. Kiren has said, but I'd like to add that besides whether it's physiological or pathological, we also want to look at whether the cause of the discharge or itchiness or whatever they are coming for is whether it is infective or not infective. And I just want to remind clinicians that don't concentrate only on the area the patient describes the problem is present. We have to have a general view, and therefore when you take a history, the history is not only related to what Dr. Kiren has said, how long have you had it, what color, how much, what do you use a panty liner and so on, but besides that, what treatment have you had? But what are the other background? Have you had a history of eczema? Have you had a history of psoriasis, for example, which are non-infective causes? And one of the other causes that is usually missed is in especially single women, if there may be a bit of odor, they use all sorts of perfumes and stuff and apply to suppress the smell as well as to, make them smell pleasant. But in the process, a lot of chemicals cause irritation. So some of these problems are induced by the patient, or from things like panty liner or different kinds of panties, and they develop a reaction. So I think what we are trying to say, the bottom line, the message that we are trying to say is think broad, think general while you are having a local problem, so that you don't miss any issues. How do you feel? That will be more appropriate.
Thanks, Dr. Raman, for the feedback. So I guess that's one of the reasons why the perfumes are selling so well nowadays. So let's look at some of the patients that we see in the days in and day out basics. For example, if this young patient, she's not sexually active, but she is suspected to have a vaginal infection due to the symptoms of excessive discharge and itchiness. So how Dr. Kiren will start investigations on this patient then?
Okay, thank you. Now this is a common scenario that I have faced in the past, where a young girl has come in, who's just started university, and comes in for her first gynecological assessment because she feels that her discharge is a little bit more and she feels itchy. She may have tried something that's over the counter, which is our first stop, going to the pharmacist, telling them, and then they would have started different kinds of medication, and the problem still persists, so she comes in. So for me, it is important to establish in terms of what's different from this discharge compared to the previous discharges that she's had, whether it is related to her period or not related to her period, and how long has she had this itching for, and does she feel that the itching is only on the outside, or does she feel that the itching is on the inside? So this is one of the first things that I would start with, apart from the fact that how long it's been going on for. Also, I would need to ask if she has been unwell in any way in the last few weeks to a month or so, where she may have had antibiotics that may have predisposed to an infection. And commonly, itching is associated with an infective cause such as candidiasis, or a non-infective cause. It could just be that she's just like any other young student who is currently having to do her own laundry, and the detergents that she's using, no longer mommy washing her clothes, she's doing it herself. So it could be just that. It could also be that she's wearing tight fitting underwear, with lycra or with spandex, and she's sweating away. Or she may be in the swim team and is going and swimming very frequently as part of the university physical activity, and she's in that swimsuit for a long period of time. So trying to establish what it is that is causing the issue. Now we know she's not sexually active, but that could just be penetrative sex. It could be that she's having oral sex. So those kind of questions need to be established. And if she's having any discharge, has she seen any discharge? Is she using, like Dr. Raman said, feminine products? Which is very, very common these days because it's advertised so frequently, make it fresh and nice smelling. So, she may be using that infrequently or maybe very frequently. She may be putting other things. She may be using a panty liner because, she's has a normal physiological discharge, but because she's in a university for a long period of time, she's, in lectures and stuff, she feels more comfortable using a panty liner. So all of those things need to be established. So based on the history, you'd have some sort of an idea as to what is going on. And then subsequently, I would go to the physical examination to have a look at the vulva and part the labia, and to look and see if there's any discharge coming out there, and see if there's anything that can be identified straight away. And often, if you can't identify it, then perhaps doing a vaginal swab may be something that can be done. At that stage, I would ask her as well if she has used tampons, if she uses tampons. And I've had cases where girls have put in tampons and have forgotten to take them out, and that can be one of the reasons why they have excessive discharge. So, if she uses tampons, even though she's not sexually active, tampons is something that is used frequently among young girls, particularly if they're going for physical activity or swimming. And then ask her to do a swab herself, or do the swab if need be, and treat empirically based on what it is that I see at that time. And my main what I would be thinking would be along the lines of candidiasis as a first line. What do you think, Dr. Raman?
That was a very complete assessment. I mean, I would agree with all of that. What I particularly like is her spandex like Superman. And nowadays, women's jeans are so tight, I wonder how they got into it and how they get out of it. Because they're so tight-fitting. And I think that's also contributing to the friction, especially when they're menstruating. And that irritation is also, I think, a contributing factor. In our medical degree, when we are taught, history does play a very important role. And I think it cannot be underestimated that the history should be extensive. You know, like how long, you know, tell me more about the discharge. Any relation to the menstrual cycle? Is it in mid-cycle? So if it's a mid-cycle clear discharge, it's probably ovulation discharge. This is physiological, you know. And then is it after that? Because if you're talking about candidiasis, it usually occurs in the second half of the cycle when the vagina is acidic. You don't get it in the first half. So if you get it in the first half where the vagina is more alkaline, then it's more likely to be either trichomoniasis or is Gardnerella vaginalis or bacterial vaginosis. It's not true, it's not really Gardnerella vaginalis, but a whole host of bacteria. So this already gives me a clue. And then go into the color. You know, is there a color? Anything other than clear or a bit of viscous discharge, if it is like yogurt or cheese, particularly Philadelphia cheese. After this, those of you who like cheese may not want to eat it, right? But you don't get this cheesy, flaky, very typical white would typical be like, candidiasis. But if it is greenish, foul smelling, then I would think of Gardnerella vaginalis. To some extent, trichomoniasis has also produced some amines. And in those conditions, the reason why you get the smell is related to the amine production by the bacteria. And these amines are like cadaverine and putrescine, which are byproducts of the breakdown. And that's why you get this fishy smell. And these are the women who start spraying around all sorts of perfumes and stuff to block the smell, right? But then color, smell, whether you use panty liner. The other thing is whether when they pass urine, they have burning pain. Sometimes herpes, especially primary herpes, can present with fever. They may have itchiness or burning sensation. They may have minimal discharge. They got vesicles, but they also have burning pain when they pass urine. So a lot of things. Then antibiotics, as she has mentioned correctly, that's one of the problems. And any other general medical disorders, diabetes, the young women who have diabetes or eczema or any other allergic reactions they have. Sometimes it's also related to drug therapy. Besides local treatment, certain drugs may give you itchiness, which may be part of a generalized itchiness or localized. So in a young woman, that would be it. And of course, the process of inspection, I've already described the discharge. A swab may be taken, and then you can look at it, but we would go straight into treatment, and whether it's a single organism or is it a mixed infection, or just reassurance. Change your panty liner, put some Vaseline so that you avoid friction. Sometimes simple remedies would be the way to go.
I see. Thank you, Dr. Raman. It looks like those are good-looking spandex. It's not doing good for the women then.
Yes.
So how about those are sexually active patients? And for example, we have a lot of colleagues who are very stressful in the daily working routines, and they may be complaining about the excessive discharge and the fishy odors. What are Dr. Raman's approach in diagnosing these groups of the patient then?
Again, we will go back to the basic principles of history, then physical examination, and finally to treatment. So here the history is, how long have you suffered from this problem? You know, which part of the menstrual cycle does this happen? Have you got many partners? Is it a single partner or do you have many partners? Do you have any pain when you actually urinate as well? Because sometimes you do get infection spreading into the urethra. Have you got any underlying medical problems? And as the partner, any symptoms? You see, and of course, color and all this would have been established. What treatment have you had so far? And the other sensitive thing is, if they have had multiple sexual partners, I would actually ask them whether they have been checked for sexually transmitted diseases, because the most likely diagnosis will be, bacterial vaginosis, which, as you know, is made up of a group of bacteria. It's not really Gardnerella vaginalis, but there are many other bacteria. Atropobium is another one. These two are the major players, and there is a whole host of other bacteria. And of course, trichomonas sometimes also do produce some amines, but the discharge is not heavy. So then we will do the inspection, and then after that we'll put in a speculum. In many of these, we might probably do a pap smear if they've not had one, because pap smear, especially the liquid-based pap smear, can actually provide diagnosis in infection. You can actually pick up candidiasis, Gardnerella vaginalis, sometimes trichomonas. So that will be an additional thing. We'll look at the nature, we look at the cervix, whether it's red. And very often, it is mixed infection. So if I see the cervix is very red like a strawberry, yes, it could be Gardnerella vaginalis. I also think whether it could be chlamydia, which is also important. So after all that and assessment, I'll see whether I think it is a simple, straightforward, single infection, or is it a mixed infection. Then if it's a single infection, then we could actually treat it simply, either orally or vaginally, depending on what you want. Okay. One of the drugs, if I think it is a mixed infection, which is very effective for Gardnerella vaginalis and atropobium, is fluomazine, which is a vaginal insert for 6 days. And also because oral therapy, many of them actually have developed resistance to metronidazole, which is the drug of choice earlier. So this is a very good alternative. So if there is mixed infection, it doesn't work well with candidiasis. It's really partial. But in Gardnerella vaginalis is a very good alternative. If you want oral therapy, then you could use metronidazole. You could give 400 milligrams maybe once or twice a day for 7 days. But remember that they cannot drink alcohol when they have it. They will get a very severe reaction. They'll vomit. And that's one way to stop them drinking alcohol. If you think there is mixed infection with fungus, you can give them diclofenac therapy as well. If they continue to have sex, and if the partner you suspect, then condoms could be used, right? But then sometimes, condoms burst, all sorts of things happen, or they fail to put the condom at the right time. So, infection may occur. And unfortunately, treatment of the partner doesn't seem to improve outcome in many of these cases. But the partner may also need to be assessed, especially if they have STDs or HIV, then of course we need to refer them to a specialist in infectious disease. What do you think, Dr. Kiren? Would you like to add on this?
I think it's important to ask how long this has been going on for, and whether this is something that is recurrent, that is coming back very frequently. So what we need to establish, I think, is whether this is a primary infection that is happening for the first time, or this is a recurrence. So recurrence to me is if they're having this kind of a symptom that comes and goes, that happens more than 3 times a year, that means we have a recurrence, and this is not a one-off treatment that can be given. And therefore then you have to follow up these women a little bit more closely and try to identify exactly what it is that we're dealing with. So one of the clues is, I think, the fishy odor. So if the fishy odor comes during a period or immediately after sex, then that is a key diagnosis, like what Dr. Raman has said about Gardnerella, which is basically bacterial vaginosis, an alteration of the vaginal flora. and then treating the person for that. But some baby, perhaps if they're having more than 3 infections a year, it should be prolonged treatment as opposed to an acute phase treatment. So a lot of the studies have shown that if you have bacterial vaginosis, it is something that most of the time is asymptomatic, and if sometimes when it becomes symptomatic, and if it occurs more than 3 times a year, then a prolonged course of treatment, and I think explanation to the women that this will be something that will come and go, and they need to stick to a treatment regime to try and see if it sorts things out and hopefully clears the infection. But very importantly as well is, just like Dr. Raman says, to rule out STDs. Not just assume that it's just bacterial vaginosis. So ruling out STDs and then treating for bacterial vaginosis in the long term for prevention, but as well as treatment. I think that's the way I would go. The other thing is, if they're using condoms or if they're using anything else, if they're using lubricants. So certain lubricants can cause allergy. So if you've got a glycerin-based lubricant, that's may trigger an infection. So that could be an allergic response to that, and that is altering the flora of the vagina. So then perhaps, taking a detailed history about that may somewhat help you to kind of reduce the recurrence of the infection.
I see. Thanks, Dr. Kiren and Dr. Raman. So it looks like if the infections is due to the sexual activities, make sure that they put on a good quality condom then. So,
no, can I say something that even if you use a good quality, you can develop condom allergy as well.
Yeah.
So you have to be careful, but sometimes vaginal discharge and some of the itchiness is related to condom allergy. That becomes a problem. And so one of the causes of vaginal discharge is also IUCD. Even the copper IUCD, they may give you this kind of reaction. And sometimes the discharge sticks onto the monofilament and also gives trouble. So these are other things that we have to look at, especially if they are using agents like IUCD. We have to be more cautious in mixed infection, especially chlamydia.
I see. I guess that from the discussions, we learned that we have to learn into really details in order to have the correct diagnosis, have to rule out the possibility of causing the infection, or it could be just an allergic response then. So it's good to know that. So another groups of the patients that we looked into today was like, usually for those pregnant ladies that may complain about the vaginal infections, and then they be presented with the excessive discharge. But when the pregnant women are having the vaginal infection, they are really cautious about the drug usage, worrying about the side effects on the baby then. So what is Dr. Kiren's strategy in managing these groups of the patient?
So in pregnancy, discharge is very common. Just like all secretions in the body increase during pregnancy. You might find that you have more saliva, you have got more vaginal secretions, you tear a lot more. So all of this are physiological. So the concern is we have to ask, what is it about the excessive vaginal discharge? So again, coming back to basics, the color of the discharge, whether there is an odor, whether, particularly if it's blood stained, is it associated with abdominal cramping or pain? Because I'm thinking like, if the cervix is starting to shorten and that's why the discharge is increasing. There is a common condition in pregnancy called an ectropion because of the hormone changes that are happening. So you have a raw area of the cervix that produces a lot more discharge. There could be a polyp there that is producing more discharge. So all of these things need to be looked at. Now, candida infection is also very common in pregnancy because it's a high estrogen state. So it is food for candida right there. So that's a common infection in pregnancy, which also is common in women who have gestational diabetes. So those are the things that may give you a clue to what is going on. It could also be bacterial vaginosis where they have a fishy smell, and that is of particular concern because bacterial vaginosis has been associated with a history of preterm birth. So those are the things that we need to look at to see what it is. And vaginal swabs may be able to help. A culture may not be able to help, but if you have you can do a PCR to help if it is to diagnose if there is bacterial vaginosis, or if she's had a previous history of bacterial vaginosis, that would be something that would be effective. You also have aerobic vaginitis, which group B strep is part of, which is a common infection in 30% of women to deal with. We have to ensure that it is actually vaginal discharge and it's not that she's peeing something and that's why she's feeling the way she is. So those are the things that we would have to ascertain. And then going back again, if there's any burning sensation, because sometimes you can have primary herpes infection in pregnancy and that causes a discharge, and that would have implications with regards to the stage of pregnancy as well as how the delivery is going to be, whether it's a primary infection, whether it's a recurrence of an infection, because a primary infection will affect the fetus and the appropriate treatment needs to be given to them at the time. So routinely I would do a speculum examination, examine the vulva, and then do a speculum examination and inspect the vagina, have a look at the cervix to identify if there's a problem, take a vaginal swab, either endocervical, high vaginal, low vaginal swab, depending on what it is that I think, and then treat the patient accordingly. So the common things, if I think it is a Candida infection, where it's very obvious, where you have white spots sticking to the lateral walls of the vagina, then a treatment with a vaginal pessary to treat that would be something that I would use. I would not use diflucan, which is an oral treatment which is known for Candida. Although having said that, the amount that is used actually has not shown to be of any harm to the baby. The studies that were done on diflucan showed it was in high doses and they were animal studies. Despite the fact that it is probably safe, I think most women would not want to take that. So the vaginal route of a vaginal pessary would be something that we would do. And if it is obvious bacterial vaginosis where there's a fishy smell and the odor is quite telling, then my drug of choice would be flomycin, because that's proven for bacterial vaginosis. It would not be oral metronidazole in pregnancy. And of course, if it is herpes infection, then treat it with oral acyclovir antiviral agents for a prolonged period of time to ensure that the levels of the viral load remains low. But certainly, again, the history and the vaginal examination would be clues. If I thought that it was because if I couldn't see anything, then I would do a transvaginal scan and look at the cervix to make sure that the cervix is not starting to shorten or to funnel, and that is why the discharge has suddenly increased. So in a nutshell is how I would approach a pregnant woman. And of course, at the end of the day, if everything is okay, to reassure her that vaginal discharge is normal in pregnancy and that we have excluded all infective causes that may be causing distress to her or distress because she thinks that it's going to affect the baby. Yes, Dr. Raman.
Thanks, Dr. Kiren. How about Dr. Raman then?
Yes, I think she has completed most of what I had to say, except that sometimes when the discharge is clear and scanty, we should not forget that it could be a hind water leaking. It could be actually a ruptured membrane, and that is also important to remember, especially when we do a speculum and we see the vagina and it looks wet, right? And then we ask them to cough and you do see some fluid, then I think we should treat it as a premature rupture of membranes unless it's past 37 weeks when it's term. This beyond the scope of this discussion to talk about preterm premature rupture of membranes, so I would not go into that. Things like antibiotic use, if they had an upper respiratory infection, they might have seen a GP, they might have put it on, that could trigger Candida infection, which is very common. GDM is very common in pregnancy, and if the control is poor, they tend to get quite a lot. And in these cases, even if you look at the vulva is very red. You know, because they also, when they pee, they have glucose in the urine. And that is irritating, and you may get even vulval candidiasis. And they're really suffering. So then you have to give a cream. And another thing is, because you are using pessary, The vagina is about 6 inches long. Now you put the pessary in halfway, your lower part is going to clear, the top part is not going to clear. So your chances of failure of treatment is going to be higher. So the best thing is insert it in the night with a special inserter. If it is not too late, before 36 weeks and there are no contraindications, I would recommend having sex with the husband with a condom. He's sure to push it right into the fornix. And that will guarantee that it stays there. And that can go on for a few days. In fact, every 3 days you can repeat it for 2 or 3 times. But we don't use oral. The rest, the treatment of Zovirax for herpes. I also just briefly want to mention on wart virus. Because wart viruses can become worse in the 3rd trimester. They may not be evident. They may present with itching. And there is treatment for that, which is, there are, applications that you can use for wart virus. And we have to discuss on the mode of delivery depending on how severe the wart is. Okay?
Thanks, Dr. Raman. So what are the common complaints I hear from the elderly or even my mothers themselves, right, is the postmenopausal symptoms, where they're presented with a typical symptoms such as a hot flush or mood swings. They also notice that they have vaginal dryness and even the recurrence of urinary tract infection there. So the question is this related to the vaginal infections? So since we're talking about the senior citizens here, so I would like to direct this question to Dr. Raman. So how will you manage these groups of patients?
Thank you for the compliment. Yes, I think I will be the appropriate person, right? Because, postmenopausal women are quite common. And as you know, our aging population worldwide, and they live very much longer, 80 years and above. Unfortunately, because of the lack of estrogen, which accompanies menopause, which by definition is 1 year of no periods. And once they get that, then besides the hot flushes, they get dry vagina, they get urinary problems. This is called the genitourinary syndrome of menopause, GSM, which is a very distressing common problem. And it starts as early as 6 months when they don't have a period. And they get burning pain. They may or may not have a discharge. And, it's a very sad thing that as we get older, the skin becomes lax. And therefore, the vagina becomes thin. Our skin here becomes very thin. So that itself, the dryness with lack of hydration, thin skin, can actually lead to itchiness. So what we need to do is this, like you absolutely correctly said, is this a feature of menopause or is there a concomitant infection? So there will come the history, but these women may not have much discharge. But my worry in a postmenopausal woman is blood. If they have periods or they have bleeding, I worry. It may be due to infection, severe infection, but I worry about malignancy, cervical, uterine, ovarian, and so on. So that would be my main area. But if it is just itchiness and dryness, then I would go through with the inspection, look outside. Many of these women also have skin problems, eczema and other things which are more common. Some of them have other skin diseases, commoner in the older women. They may have applied stuff on it that may irritate the vulva. And I would then proceed to actually put in a speculum and see whether there is evidence of infection. If they hadn't had a pap smear, recently I would do a pap smear. If I see obvious discharge, I would actually do a swab. I'm also very sensitive that most of these women, if I look the vulva is red, I would actually check them for sugar. Many of them actually unknowingly present, they are actually diabetic and they present with itchiness for the first time in that age group. So that is one thing that I would do that. But if generally everything is good and if it's just a local thing, then I'll treat them with estrogen, topical estrogen. even externally as well as vaginally. And this is where one of your products, the Gynoflor, becomes very useful, because it restores the estrogenizes the vaginal epithelium, and it also has lactobacillus, which is also very good to make the vagina a young woman again. So there you are, it is 2 in 1. So that would be one of the treatments. But if there is infection, I will proceed along the same lines, oral or vaginal treatment if it's candidiasis. If there is diabetes, I think I will definitely want to control the diabetes. And then after that, if the vagina is very thin, I would consider the use of Gynoflor. There's also a recent paper, which is in May 2020, of the use of a similar probiotic, Lactin V, which actually is Lactobacillus crispatus. You all use Lactobacillus acidophilus. And a 12-day treatment with this, especially with bacterial vaginal cysts, with metronidazole, you'll find that the recurrence rate is much lower. So I think that would be the approach. I'll be more worried about general problems, exclude any malignancy or potential malignancy, and only treat if there is just vaginal atrophy, which is a common cause and leads to easier infection. What do you think, Kiren? Do you agree?
I think I agree with you in terms of the approach to someone who is perimenopausal or postmenopausal, excluding all the common causes. But again, while she's at that age, sexually transmitted diseases can also occur. So to establish that there isn't a sexually transmitted disease going on there, excluding that, and then coming back to her symptoms with regards to the dryness and the itching, whether it's specifically on the outside or is it on the inside, is it worse after sex or is it there all the time? So again, in this age group where the lubrication is a lot less, lubricants that are used may be a cause of an allergy, predisposing them to have this itching. And a common thing that I see in this age group is women douching, because they feel that they're itchy and they feel that, you know, they need to clean themselves. They go to the pharmacy, they go and get a betadine wash, they use water, they use all sorts of things. So to establish that that is not happening, and if there is, then educate them about it and, you know, perhaps tell them that that's not the way. And then treat, as Dr. Raman says, with topical estrogen. Because even if someone is on HRT and oral preparation, it doesn't go to the vagina. So you may have to, in addition, give them a topical preparation. And Gynoflor is something that I use frequently. It is 0.03% estriol. So if people are afraid of using estradiol with a Premarin cream, then this is estriol and it's only in the vagina. And the best way to do it is, you know, with anyone who has this problem that is ongoing, to start a loading dose. That means using it once a day, every night for 12 nights, and then using it once or twice a week for a few months to see how they feel. I think using it sporadically is not going to solve the problem, because this is a problem that is going to be ongoing. And I think identifying what it is, assuming that everything else has been taken into account, and that this is purely, the old term for it is that is causing the symptoms, then treating them for that so that they have a good quality of life. It's not nice going to the toilet all the time, and it's not nice when you can't have good sex at this age. So I think treating the cause, excluding all the other things that can be pathological, is the way to go.
I see. Thank you, Dr. Kiren. It sounds like the usage of the estrogens will help to restore the elasticity. So perhaps the estrogens topical cream may help in uplifting our skin at some day as well. So let's talk about types of patients that we discussed earlier. We mentioned about the recurrence of vaginal infections, and this could be quite difficult to manage because the patient keep coming back with the vaginal infections. So what are the strategies would Dr. Kiren use to manage these particular groups of patients?
Okay, so in terms of recurrence, is someone who has had 3 or more infections. if we take candidiasis, for example, if they have a recurrent candida infection, we have to go back to the cause of the infection, diet, antibiotic use, overzealous use of products, and educating them that feminine wash is not recommended, douching is not recommended, the vagina is a self-cleaning organ, it should clean itself. Then if you look at the data out there, it says that if someone has recurrent candidiasis, there is no need to treat the partner. However, there is evidence that if a man is not circumcised, they can be harboring the infection underneath the foreskin. So that it may be worth looking at that. There are also studies that have shown that the only way to combat a recurrent candida infection is to use treatment long term. So anything up to 4 to 6 months of recurrent use in the long term will reduce the recurrence of the infection. Now, a small portion of these women would still have a breakthrough recurrence. And if that is the case, then a longer term treatment like a oral diflucan tablet every week for a whole year has been advocated, but bearing in mind making sure the liver function and all that is normal. So far to date, using a tablet of a low dose tablet has not shown to have any adverse outcomes. So I think that is very important. Now, if the person is diabetic or pre-diabetic, she's also predisposed to it. So certainly diet control, lifestyle, using the correct underwear, cotton underwear that is self-absorbing, not using panty liners, or perhaps using an organic panty liner or a washable panty liner which absorbs things a little bit better, may be the way to go. So it has to be taken on a case-to-case basis. So I'm talking about candidiasis. I think Dr. Raman can talk about bacterial vaginosis.
Well, if I could say a few things about recurrent candidiasis, it's a very distressing problem. And as you correctly said, metabolic disease or autoimmune disease, steroid use, those who are immunocompromised, HIV, chronic HIV, all these you have to make sure you've excluded as a cause. The other thing is, if they are on the obese side, I will actually like to get them to reduce weight. That may actually help the insulin resistance. And I usually make them go on a strict diet where they cut sugar intake.
Successful?
Now, it is. In quite a number of them, I find out. The thing is, you also have to look at their lifestyle, and a lot of this recurrence is actually intestinal candidiasis. And the way they wipe themselves instead of front to back to front when they go to the toilet, they spread candidiasis into the vagina. That's another issue. You've got to talk about hygiene. And I give them oral nystatin as well to try and clear intestinal candidiasis. Now, we know that the major cause of candidiasis is Candida albicans. But we also have these Glabrata tropicalis and Scruzii and there are a whole lot of others. These are the ones that actually work on becoming resistant. They are not sensitive to the ikonozoles or fluconozoles. And actually, there is no proper treatment which will eradicate them. The only other thing that has been mentioned in the literature, which I have not used because it's not available here, is boric acid. And boric acid, it's like a capsule form put into the vagina, is supposed to be useful. And avoid unnecessary douching. And like she says, long-term use of a mixture. You can even use vaginal cotrimazole. You can even use those intermittently with oral fluconazole, oral diflucan, fluconazole, up to 6 months. But she's right, there'll still be a breakthrough, but many of them actually tend to improve because with time with improving in immunity, they actually do improve. But recurrence is common, very distressing. Regarding bacterial vaginosis, it's also another distressing problem. It can be recurrent. And that's why we have to look at the partner. We have to exclude SCD, immunocompromised conditions, HIV, and so on. Drug treatment like steroid for, say, SLE and all those things which can reduce your immunity, which can also give you infections. And we may have to continue treatment. Again, treatment of the partner has not been very promising, but you can try treatment. And of course, use of condoms if they're not allergic is another treatment, and they may require multiple courses of metronidazole or clindamycin, which is another drug that has been used, or you can use tinidazole. There are other things that you can use. There are some rarer causes more in children. So we have not talked about children, but in young children, I've actually pulled out things like beads and guava stuff and all that, because they tend to, before they get the periods, they are very inquisitive of the bodies. They tend to shove into the nose or into the vagina. And in a psychiatric woman, I've actually pulled out a bottle cap which has been put into the vagina, and she was having foul-smelling discharge. And I really had to use a forceps to pull out the damn thing. So, foreign bodies are not uncommon, and especially if they are on unsound mind, you may actually find strange things in the vagina, right? And this all has been reported, just for making it a bit more out of the box, that you may actually find other reasons, especially in young children. And lastly, in younger children also, pinworms. Many of them actually do have pinworms. They come out from the anus in the night and lay the eggs around the vulva. And they are a common cause of infection in young children. Although this is not part of what we are doing, I think we got to think general and cover more exotic causes, especially in extremes of age. Thank you.
Thank you, Dr. Raman, for sharing those exotic cases. It's quite surprised that, well, I guess that the toys don't go well with the vagina in this case then. So thank you very much for both Dr. Raman and Dr. Kiren for all your inputs. I'm quite sure there are quite a number of take-home message for today's discussions. So how about we get Dr. Kiren and Dr. Raman to share with these 3 take-home message for our audience then?
After you.
Okay, so basically, vaginal infections are common. The way to treat vaginal infections is to take a good history, to do a good physical examination, to investigate in the first sitting to see what is going on, and then treat them appropriately as we have discussed earlier. So for each and every person from whichever stage of life, these are the basic factors. And as Dr. Raman says, think outside the box and see if there's anything else that can be contributing to their symptom of vaginal infection.
Sure.
Just to add to that, only, as I said, when you think of vaginal infection, is it physiological or is it pathological? And if it is pathological, is it infective or not infective? So if I want to give you a take-home message, that's all. These 4 things. Thank you.
Thank you, Dr. Raman. Thank you, Dr. Kiren.
Thank you.
So if for all the audience, if you have any questions, please type them in the Q&A box. We'll try to address it during the session then. Thank you.
Thank you.
Go.
Hello, Dr. Raman. Hello, Dr. Kiren. Welcome to the scenes again. So we were blessed with abundance of questions. I'm really excited to share those questions with doctors and hope that doctors can help to address all these questions by our audience. And let's get going with our very first questions. The first question is very basic. So what's a normal vaginal discharge? Is it okay to be slightly foul smelling? I think I'll direct these questions to Dr. Kiren.
Thank you, June. Vaginal discharge is very normal. It happens throughout your cycle, and with each stage of the cycle, the discharge is very different. Immediately after a period, you will find that the discharge, there's not much discharge there until coming up to a few days before ovulation, where your discharge turns a little bit more slimy, a little bit more clear. And after ovulation, it becomes a little bit more thick. Some people describe it as pure white, some people describe it as milky, some people describe it as slightly yellow. But one thing is common amongst all the discharge. There shouldn't be much of a smell. There can be a slightly stronger odor, but there should not be any smell. So if there is smell, then it is something that we need to address. It could be an abnormal discharge. It could be something that is brewing in there, and therefore needs to be addressed by themselves, or if they go to their doctors, and particularly if it's persistent.
Yes, sure. Thanks, Dr. Kiren. It looks like when the moments there's a foul smelling, so it's better to get the checkup then. So the next question is about the menstrual discharge, and since they are going for the senior people, then I'll go for the senior doctors here, to Dr. Raman. So how can the post-menstrual discharge be treated in the women then?
Yeah, I think we will always go back to basics. When does it occur? How much does it disturb your daily life? Does it stain your panties? What color is it? What smell and then does it interfere with sexual function and so on? So I think once you have got the basic idea, then you want to know whether this is a pathological discharge. And in an older woman, then it will require an inspection outside and then a speculum examination. And if they haven't had a pap smear, they're below 65, I would do a pap smear. And if there is any discharge, I can also do a swab and send it to the lab for culture and sensitivity. Based on what we see, then we can consider appropriate treatment.
I see.
If there is an obvious infection like candidiasis, but I always am sensitive to the fact that in the older person, many of them have comorbidities, particularly diabetes.
Yep.
So sometimes the first presenting sign of a candida infection is actually underlying diabetes. So I would get the sugar checked and so on. So I think I'll look outside the box.
Sure.
Sometimes it is not related to discharge, but a skin problem. Because as they get older and they're not on HRT, the vagina and the vulva tends to shrink and they actually have itchiness. But that would require treatment with some form of hormone treatment. Externally as well as vaginally. And in the vagina, it's atrophic. Otherwise looks healthy, then the use of Gynoflor would be where you give probiotics and estriol to rejuvenate the vagina will be useful.
Yes, yes. Thanks, Dr. Rama, for the comment. So it looks like the depletions of estrogen does play a role, and restorations of estrogens are crucial then. So that's another question that related to menstruals that I will direct to Dr. Raman as well. Do you personally advocate for menstrual cup? So what will be the risk of the menstrual cup causing the infection then?
I'm sorry, menstrual?
Cup, menstrual cup.
Cup?
Yes, menstrual cups. So I believe that this is actually the devices that use it during the menstrual cycles, right?
Correct.
I think I will ask Dr. Kiren to answer this.
Okay.
There are some women who believe, particularly in Europe, particularly in women who are in their 30s and onwards, that use menstrual cup during their periods, and they change the menstrual cup, or they tip it, empty it, wash it, and put it back in.
Oh, I see.
2 to 3 times a day, because they want to be environmentally friendly. They don't want to use sanitary napkins. They don't want to use tampons. So these are a group of women who perhaps may have had allergies to this kind of products, and therefore found that when they were using the menstrual cup, they feel a lot better. But the menstrual cup use per se is not common. It is in a small population of patients, and it does not seem to increase any infections because of the use of menstrual cups. What infection would be is if you don't wash your hands properly, you're introducing infection while putting in the menstrual cup. But if you wash your hands properly and then you put the menstrual cup in, so far there hasn't been any increased amount of infection that is related to the frequent use of menstrual cups.
Sure.
What material is the menstrual cup made of?
I think it's a silicone kind of thing.
So it's like a diaphragm, almost like a diaphragm.
Yes, and they have different sizes, so it depends on how it fits in that.
Yes.
And they have to be fitted.
Yes, and now I get it, because yes, there have been some mention of this, but I didn't realize it's just called a menstrual cup. Yeah, but again, like all things, it can, although the numbers are small, whenever you put something in, you must remember that you must take it out as well.
Yeah.
And if it is impacted, especially in the elderly, we have had rings that are impacted, and all this stuff that are left in can predispose to infection.
Sure.
Good.
Sure.
I'm glad Dr. Kiren came to the rescue.
So we do.
I think it's very important that women who are using it, as Dr. Raman rightly said, remember to remove it, because both of us have come across women who had tampons put in and accidentally forgotten that they're there.
That's
and
right.
then come to us because they have smelly discharge that has been persisting over months, getting worse after a period or after sex, and when we do a speculum examination, lo and behold, there's a tampon sitting in there. It's not unusual. We infrequently see it, but we do definitely see things left up there.
Yep. But that comes to younger children, especially when they have foul-smelling discharge. You see a lot of foreign bodies, and now with different kind of sexual experience where people are putting in all sorts of things into the vagina, you can actually get retained foreign bodies, and they can actually give you foul-smelling discharge. Sure. It's common in young girls, because when they are in the process of exploring the body, I've seen beads put in, a 5-cent coin put inside the vagina, and so on. So, you have to be mindful of such things.
So Dr. Raman and Dr. Kiren, let's talk a little bit on the recurrence infections. If the patients keep coming back, let's say keep coming back with the Candida types of infections, right? What would be after all the examinations, then it was confirmed that it's just a common types of Candida albicans types of infection. So what would be your approach? Is there any approach to prevent futures infection then? So I think I can direct this question to Dr. Kiren.
Okay, so once you have repeated Candida infection and you have ruled out all the causes, like Dr. Raman has said, other causes, medical problems that can cause that, and you have typed the Candida to ensure that you're actually treating it correctly. So if it is Candida albicans, which is the commonest type of Candida, and that is sensitive to most of our over-the-counter medications, the azoles that we use, the fluconazole tablets that we use, the nystatin pessaries that you can use it. But for most women who have recurrence, that means that they have had 3 or more infections in a year, you might find that you may need to use repeated doses of vaginal pessaries or oral tablets weekly up to about 4 to 6 months to reduce the recurrence rate of the Candida, and that is what's shown in most studies to be the most effective. There's also the role of improving the flora of the vagina by putting in pessaries that have got lactobacilli in that. There are also studies to show that eradication of the Candida source in the gut, which I think Dr. Raman mentioned previously, by giving nystatin tablets to eradicate that. So those are the things that we have to eradicate. But going back to simpler things, like looking at lifestyle, what kind of lifestyle the person has, what kind of diet the person has, if that is in any way contributing to it, and also looking at when in the menstrual cycle the person gets Candida infections. Is it usually it's before the cycle, or is it after the cycle, and then trying to target those areas and putting in pessaries. So even if you have to put in pessaries on a weekly basis for up to 6 months, it does not create resistance
to the infection, as long as we know that we are treating the right infection. So
if I may add,
difficult, but that is one of those things that we would have to do, and to also prevent the girls from doing douching, because sometimes it feels very itchy. What they are doing is they are douching with all the over-the-counter products, and that might be counterproductive. While you're trying to treat someone, they are douching it, they are altering the vaginal flora.
Sure. So Dr. Raman, you may need to want to add some things, right?
Yeah, no, I think she has done a good job and covered most of the bases. I mean, a lot of the definitions for Candida are 4 or more infections a year. And remember that it is the Candida albicans, which is the commonest, and 70% and these are easily treatable, provided you have excluded medical causes and other causes. But when it comes to the Tropicalis, glabrata, and Cousii, and there are many other varieties of Candida, they are actually resistant to most treatment.
Yep.
In fact, there's almost no treatment for these kind of Candida, which you can only find out if you do advanced culture. Boric acid pessaries has been recommended. I have not used them, but generally, lifestyle, very low sugar intake, oral nystatin to clear the GI, long-term use of oral and vaginal pessaries, because you must understand that when you use a vaginal pessary, that the Candida is not only superficial, but actually goes into the lower layers of the epithelium. And so in 3 to 4 days, actually, the vaginal epithelium, the superficial layer is shed, but then the Candida is clean. But then the budding yeasts, which are in the deeper layers, now become superficial. And that's why even if you use pessaries, you tend to use them every 3 days to insert. Or even if you use fluconazole, you would like to give them every few days, 3 days interval for this cycle. And in HIV positive, you can get systemic candidiasis, and those have to be treated by intravenous antifungals, which are very toxic. So one has to be aware of sexually transmitted disease. So we need to screen them if they are recurrent for STDs as well, including HIV. And I think immunosuppression from any other cause, steroid treatment, all this can predispose to persistent Candida infection.
Sure. Thank you, Dr. Raman and Dr. Kiren. So we are briefly talking about the roles of the probiotics in the restorations in the ecosystem. So there have always been discussions about whether we should use the orals or using a locals probiotics. What's doctors' comments on the options here in the restorations of the vaginas? Maybe we start with Dr. Kiren first.
Okay, so if we are of the idea that the gut is the reservoir for fungal infection, then I think treating the gut over a period of time, the aim of the exercise through probiotics is to restore the gut microbiome. And with that, the vaginal microbiome is supposed to be restored as well. And I've had plenty of success in women taking oral pre and probiotics over a period of time. And you need to take this for at least about 3 to 6 months to reduce the recurrence of vaginal infection.
Sure.
In addition to that, the only probiotic that we have vaginally on the market in Malaysia is Gynecologist. So Gynecologist has got Lactobacillus acidophilus in there with a little bit of estrogen, because we need the estrogen, estriol, 0.03% of estriol, together with the lactobacilli in order to produce the lactic acid and the hydrogen peroxide, in order to acidify the vagina, in order to prevent the infection. So infections come in the vagina because of the upset of the microbiome of the vagina. That happens for whatever reason. Due to antibiotic use, due to sexual activity, due to douching, due to stress. So these products are an adjunct therapy to kind of reduce the recurrence rates of these infections. It does not mean that it's going to cure the infection.
Yep.
It means that it's going to reduce the recurrence, and this is something that has to be done long term.
That's right.
Because the infection has been there long term. It's not something that's happened and then you can cure it. So in the women who have recurrence, this is one of the things that we have as an adjunct therapy to try and minimize the repeated infections that we have. So it's like a two-pronged approach, one in the gut and one in the vagina.
Sure. Thanks, Dr. Kiren. Dr. Raman, do you have anything to add on about the
Yes, because even in bacillus vaginosis or one of the problems is the low level of lactobacillus in the vagina. They're actually very depleted. So after you have given the treatment for bacterial vaginosis, which could be oral or vaginal, and here I would say like flumozine is very good. And by the way, it is effective in Candida, but it's much less. The mechanism of action is different. So sometimes when there is resistant candidiasis, I tend to try flumozine in these patients because the mechanism of action is on the scent wall and on the DNA and so on. And they act differently from the azoles. So I tried that. So even after their vagina has been restored, you can actually give them a course of Gynophlow probiotics. Now, oral probiotics, which Dr. Kiren has talked about, is good for general health. And a lot of these women have irritable bowel disease and constipation and so on. So I think pre and probiotics are very good. And they do increase the immunity because they are the largest immune stimulators other than vitamin D, vitamin C, and so on. So they are good, but for the vagina, there is Gynophlow, and the other is this paper that I mentioned last year in May in the New England Journal, Lactin B, which is also lactobacillus, but it's crispatus, which is used in the vagina.
Okay, thanks, Dr. Raman. So one of the questions that we see several times here was that they're talking about the usage of the pessary. So the questions will be like, should we be using the fingers or should we be using the applicators, especially among those pregnant women? So perhaps I will direct these questions to Dr. Raman then. So how do we ensure that the pessaries is inserted properly? I know you have a totally different views on that.
Why they fail is because you haven't inserted the pessary deep enough. So we normally tell them to insert it at night, last thing at night. But pregnant women get up and go to the toilet very often. So if they don't insert it often enough or very quickly they go to the toilet, it will be only halfway. So the lower end of the vagina gets sorted out, but the fornix and the posterior fornix and the higher end, you still have infection. So yes, you could use an applicator, but applicators sometimes in women who have delivered 3 or 4 children, the vaginal wall literally falls in. It's not easy to insert. They might find it painful and sometimes they might actually injure the wall. When you insert with the finger, it's not deep enough. So I mentioned this, that it's not a contraindication as far as I'm concerned. If the woman has no ruptured membranes or premature labor or anything, is the husband can use a condom and even have sex, which will actually push it in. But the principle of it is do it, but remain static for a while and don't immediately walk around. Let the pessary dissolve first, so that it will work all the way down and it will be better.
Okay. I think the take-home message here was insert with tender care, but we need to insert deep enough then. So
the posterior fornix as deep as possible, leave it to dissolve a bit because the pessary is very firm. And then later, if she mobilizes herself, then it'll still be successful.
The next questions I'm going to ask is related to those non-sexually active women. So I will direct these questions to Dr. Kiren. So Dr. Kiren, how would you do swab in these groups of women? And also the question is, when they come down, let's say the woman is having the vaginal infection, is there a role for the pessary in this case for the groups of women who is not sexually active?
Okay, thank you for that question. Since we see a lot of young girls who have infections, Now, what I would normally do is back to basics, apart from the history and everything, and assuming that my thought process is that it is a candida infection, assuming that there hasn't been anything else, she hasn't been inserting anything, she hasn't had oral sex, which can possibly be contributing to what she's having, then, and assuming all of that is no, then, and she's had a course of antibiotics perhaps, and you think that it is a candida infection. So basically physical examination, looking at the labia to see if there is any inflammation, to see if there's any excoriation marks, like she's been busy scratching because it's so itchy. And then to do a swab is relatively easy because there are young girls who use tampons in the vagina when they want to go swimming, for example. So what I would do is part the labia and see if there's any discharge on the labia, take a swab and take the swab off the vaginal vulval area. But I think most important before you do anything is talk to the person. Speak to the person and say, this is what I'm going to do. Show them the swab that you're going to do and show them how tiny it is. Position them correctly. And allow them to, if they're concerned, have a mirror to see what you're doing. And once you part the labia and you've done all of those things and you put the person at ease, then you take the swab and you go down into the posterior part of the vagina where the hymen is, go through the hymen and roll around in the vagina. It's not painful. They will not feel very much if you go through the hymen, the hole in the middle of the hymen clearly. But of course, if you're going to press onto the hymen or press anywhere else, then it's going to be a problem. But once the swab is inside the vagina and you swab the area, you will not have any discomfort. Once you have taken the swab, you can, of course, it takes about 2 to 3 days for the results to come back, but you can empirically treat them. And I would not, pessaries would not be my first choice. I would use oral fluconazole as a treatment. And depending on the type of history that I get, it may not just be a one-off pessary. It may be something that I will have to repeat on a 3rd or 5th day or 2 or 3 times in order to get the effective treatment for that person, the effective treatment modality of the person. So I routinely do swabs in my younger girls when I want to get a confirmation, and they tolerate it quite well.
Okay. So we have too many questions and we still need to watch.
Can I just add something? Now, in young girls who have not been sexually active and you think that there is a foreign body, there may be a foreign body, can I suggest that you can use labial ultrasound, translabial ultrasound, to have a look into the vagina, because you don't need to insert it. You use the normal probe, cover it with a glove and put some gel and just place it in between the labia and look at the vagina and see if there's anything suspicious inside. That's a simple, non-invasive way which you can try, and you may be able, in fact, if you're experienced enough, you can actually see vaginal discharge. It comes out as white streaks, and whether it's in the posterior fornix. So that may be another additional guide, because the only other way, if you suspect it, is take them into the operating theater and you have to put a hysteroscope or something inside to have a look, because
that is what we routinely used to do in the UK, like all these young girls coming in with assisted discharge. The number of hysteroscopies that we had done of the vagina, flush it out and see what was going on, was quite amazing. We didn't have the ability of having ultrasound scans in the outpatient setting.
Sure. I think I'll ask the very last question, because this is actually quite an interesting question. So is regular douching advisable, and does chuka water help to reduce the infection? I think I will direct that question to Dr. Raman then.
Oh dear. Now, as it is, as you know, douching is not recommended, because if you have infection, you may actually, and especially it's mixed infection with gonorrhea, there's one sure way of pushing it into the uterus, into the tubes, and cause infertility. So I know all sorts of strange things have been put, and people used to use potassium permanganate, this purple color in Along, Jalan Aloy, and all the prostitutes that come asking for this purple water, and they used to douche thinking that, the vagina is sterile and they're going to get STD. Not true. I think douching in principle should be avoided. And if I understand correctly, I'm told that this is vinegar. We only use a dilute form of vinegar to have a look at the cervix during colposcopy. But if it is very strong, it's very strongly acidic, then it may actually cause chemical injury to the vagina. So our aim is not to pickle the vagina, but, and not irritate it further. I think we should avoid douching in general.
Okay, thanks, Dr. Raman, for the reply. Dr. Kiren, would you like to add anything else?
I think vaginal discharge is a common gynae presentation. I think the idea of knowing what is physiological and what is not, and managing the person from the word go is probably something that will benefit both your patients and us, rather than having to manage this recurrent vaginal infections. So I hope that after this chat that we've had, that everyone is a little bit more aware and more confident in terms of managing this.
Thanks, Dr. Kiren. Thank you, Dr. Raman, as well.
Thank
you both, doctor, for the very insightful sharing, and also thanks to all the audience for the overwhelming questions. Where so many of them, we don't have time to go through that. I just received the reply from our product manager. We'll organize a forum to address the questions here, so that we get the reply to all the exciting questions posted here. Then, so our next session is on the pediatrics, allergics, and conjunctivitis. We will start at 1 p.m. then. So stay tuned with us to learn from the Dr. Fazilawati then. So please drop by our booth in the meantime to learn about the DKSH product range. Thanks, Dr. Raman and Dr. Kiren. Looking forward to catch both of you all in the future. Thank you.
Thank you.